Hello, my name is Matthew Tillman, and I'd like to thank the organizing committee for the opportunity to present my talk titled Management of Large Bowel Obstruction. I have no disclosures. We've all seen these patients in the emergency room, and they're a challenging group to manage, but I'd like to convince you that it's not just a plumbing issue. There are many things to consider when managing these complex patients. The etiology, colorectal cancer is the most common cause, about 60% of large bowel obstructions, diverticular disease. Then volvulus pseudo-obstruction is not common, but we'll touch on it today. Our main focus is going to be the management of colorectal cancer and malignant large bowel obstructions. Presentation will differ based on either if it's a partial versus complete obstruction and the etiology, which will also determine the best management approach. Initial management is similar. Resuscitation, NG tube decompression can be helpful if the ileocecal valve is incompetent, but usually it's not. Plain films are helpful, but CT is really the workhorse and the mainstay of assessing the etiology and looking for any associated complications. And endoscopy can be both diagnostic and therapeutic, so it should be done if it's possible. The most common cause is malignant large bowel obstruction. It's the initial presentation in 30% of colon cancer patients. There's a high risk of bowel ischemia and perforation with the attendant morbidity and mortality and worse oncologic outcomes. It's most commonly on the left side in the sigmoid colon, and usually is intrinsic unifocal, although it can be from peritoneal disease. Management objectives: number one, relieve the obstruction, maintain oncologic principles, and consider the quality of life and returning the patient to intended oncologic therapy. Main treatment options are going to be urgent surgical resection, proximal diversion, and endoscopic stenting, and treatment should be prioritized by intent, either curative or palliative. Which intervention to choose is based on many factors. There are procedural factors such as the resectability of the disease, also technical factors when it comes to stenting. Do you have the expertise? And you really should weigh the impact on short and long-term oncologic outcome and any limitations that the intervention will have on the patient. Disease factors include metastatic or locally advanced disease. Does the patient need neoadjuvant therapy, or are there other therapeutic options that the patient can go on to? And also patient factors. Urgent surgical resection for curative intent. It is associated with high mortality, much higher than elective resection, about 13% in some studies. And the oncologic outcomes are inferior. There's increased local occurrence and distant failure as a whole, and the 5-year cancer-specific survival is low. Staged operations are common in this group. Current stoma rate can be as high as 30%, but primary resection can be done. It is safe in selected patients. And the extent of bowel resection, try to do segmental resection, but if there's ischemia of the proximal colon, sometimes a total abdominal colectomy needs to be performed. You should maintain oncologic principles, doing a central lymphadenectomy, and make sure you have good margins. For right-sided obstructions, this approach is more common. About 70% of the time, the primary is resected at presentation. The anastomotic leak rate is much higher than in the non-emergent setting, and interestingly is higher in right-sided patients than left-sided patients, with a much worse mortality if that complication happens. So in patients that are unfit, or if you're unable to get a margin negative resection, diversion is probably the next best step, and you can get them on a neoadjuvant treatment. Even in perforated cancers, it's safe to do that if it's a contained perforation. The patient is diverted, as the positive resection margin rate is much higher in the emergent setting, as high as 30%. And stenting is possible, but there's a much lower success rate, and it's technically very challenging, so rarely done. Left-sided obstructions are more common and also more challenging. And as you've seen, the mortality and morbidity from emergent surgery are worse than elective. So how can we improve on this? How can we decrease the stoma rates and also possibly improve oncologic outcomes? One strategy is the bridge to surgery strategy. It allows for correction of physiologic abnormalities, normalize the bowel caliber, and allow for completion of staging and the diagnostic workup. And if any neoadjuvant therapy is needed, it allows you to do that and decrease the morbidity and time away from intended treatment. The two options are going to be a diverting stoma or stent. There's not much data or studies between a stoma versus a stent, but this study was done with a stoma versus surgery. It was actually a meta-analysis back in 2015. And what they found is the morbidity and mortality actually the same between surgery and the stent group, or the stoma group, but the stoma group had fewer permanent stomas and more likely to have a primary anastomosis. So considerations when you're doing a diverting stoma as a bridge to surgery, you need to make it easy to construct and reverse. These patients are generally sick, and you need to be expedient with your care. Minimally invasive approach is possible. A colostomy is preferred, although an ileostomy is a consideration. And a diverting stoma is really the preferred treatment for rectal cancers, anything below the peritoneal reflection, and given the high rate of stent complications there. And then you need to think about your future resection. Where you put your stoma, is it going to jeopardize your ability to do a primary anastomosis in the future or injure the conduit? And you need to document your findings at that time since you're going to be in there. Stents are another option. They were introduced in the 1990s with a lot of excitement as either a definitive treatment for palliation or a bridge to surgery. There's been many, many studies. A large number of them are retrospective cohort studies and conflicting results. There's a lot of heterogeneity in this patient population and in these studies, so it makes the data difficult to interpret. And the intention of the treatment is difficult to determine in an emergent setting, so it's a difficult group of patients. These were two large randomized controlled trials, early randomized controlled trials about a decade ago. The one on the left is a French study, and they found they're able to successfully treat the obstruction at 50% of the time, but there's 3 stent-related perforations. And when they looked at some of the surgically excised specimens, there was a total of 20% occult perforations that were not seen at the time of stenting. And that study was closed early because of that. And in this study in the Lancet, it was a Dutch study. It showed a higher success rate of 70%, but the perforation rate was 13%. And both of these were closed due to the concern of perforation and tumor spreading. So we've had more experience with stenting over the past decade. And this is another study that looked at stent versus emergency surgery as a bridge to surgery versus definitive care, and they had a high success rate, 82%, but again, a perforation rate of 5% versus none with surgery. There are fewer stomas, 70% in the emergency surgery group and 45% in the stent group, and the 1-year mortality, length of stay, and quality of life were the same between these patients, and these were all comers with large bowel obstruction, left-sided large bowel obstruction. This was the largest study, 312 patients, randomized study in a randomized controlled trial in Japan, and there was a very high success rate, 98%, and around a 2% perforation rate and a high number of primary anastomoses. This is a very high volume center that did stenting routinely. And there was a concern in the earlier trials about perforation and the worse oncologic outcome. We don't have some long-term or 5-year survival for some of these trials, but this study back in 2017 reported their 3-year disease-free survival, and it was no difference between stenting and emergency surgery. So when you take the data as a whole, there's benefits of stenting versus surgery, which include more minimally invasive approaches are done at the end. There's higher primary anastomosis and fewer stomas. But the perforation rate is higher than surgery and an ostomy, obviously, and the failure rate is higher than surgery and an ostomy, and risk factors for that are complete obstruction and a tumor larger than 4 centimeters and it flexures. And there's a question about recurrence, especially if there's perforation. We know there's a double risk of recurrence, so we need some more studies. And overall survival and mortality are similar to surgery. So it's something to discuss with the patient. Expertise is required, and there's a high rate of failure at the flexures. And in the rectum, there's severe tenesmus and pain that really limits its utilization. In the palliative setting, the main goal is going to be getting the patient back to oncologic therapy and maintain their quality of life. Palliative resection can be done, but there's questionable benefit for oncologic outcome, and should only be done if it is straightforward and the patient is otherwise fit. And a stoma is going to be preferred for rectal sigmoid lesions. Stenting, it is reserved for high-risk patients with short life expectancy and those with disseminated disease, peritoneal disease, because it comes with a lot of risk. The delayed perforation rate in the 40% in the adjuvant treatment group. There are reobstructions that occur and a very high rate of perforation in the bevacizumab group. So, and also best supportive care is another option. This is our individualized approach at MD Anderson. Really, stenting is reserved for patients, again, that have a short life expectancy. It's above the peritoneal reflection. Resection can be done. And for bridge to surgery, if the patient's on or going to need VEGF therapy, then an ostomy really should be done. Otherwise, stenting can be done if the surgery is otherwise going to compromise the oncologic outcome. Colonic volvulus is the second most common cause. It's more common in the East. Sigmoid is the most common site. Cecal volvulus happens about a quarter of the time, and a high risk of ischemia and perforation in this group. Staple patients can be treated, or diagnosis is done by CT. Endoscopic torsion is the first line treatment. Has a very high success rate. Recurrence rate is high though, and surgical resection with primary anastomosis should be offered at the initial, at the index admission. Cecal volvulus really needs to be resected because the torsion does not work. And Ogilvie syndrome, it is not common, but it is a cause of, a non-mechanical cause of large bowel obstruction, usually older patients associated with trauma and medications like opioids. But you really need to exclude large bowel obstruction, and a CT is going to be your most reliable way to do that with contrast. Management is non-operative for the majority of patients. Neostigmine has been well studied and is safe if patients fail non-operative management. And endoscopic decompression can be done if neostigmine fails. And surgery is limited to patients with peritonitis or with their cecal diameters larger than 14 centimeters, just because of the risk of impending perforation. Thank you. I'll take any questions.